Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you, and we aim to take around 15 to 20 minutes. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Welcome to this very first episode of Glenohumeral Gurus. I'm your host, Dr Margie Olds, and I am beyond excited to embark on this journey with you. In this podcast series, we'll dive deep into the world of shoulder therapy, exploring expert insights, evidence-based practice, controversial discussions, and engaging discourse to help you enhance your clinical skills and improve outcomes for people with shoulder problems. Today, I'll give you a brief overview of what you can expect from this podcast. We'll cover everything from shoulder pathology and common issues like rotator cuff-related pain to practical tips and real-world case studies. In future episodes, we'll have interviews with leading professionals in the field, providing you with the latest insights into their research and some clinically relevant takeaways for you. But first, let me share a bit about myself and why I started this podcast. I work as a specialist shoulder therapist here in New Zealand. I see many shoulder patients on referral from sports doctors, surgeons, and physios. All my patients have had previously unsuccessful physio, and my job is to establish if physiotherapy could be still useful to these patients, and if so, what that looks like, or whether the patient has reached the end of the conservative road. It's an extremely challenging role, but also very rewarding. Prior to this, I worked as a shoulder therapist, and before this, I worked in elite sport as the lead therapist for the British Canoe Union and have attended the Olympic Games in this capacity. It was here that my passion and desire to improve outcomes for people with shoulder instability really began. When one of my athletes dislocated her shoulder in the run-in to the Olympic Games, I began to realize how limited the research was in this area and how much we didn't really know about conservative treatment for shoulder instability. And this was in 2004, and now some 20 years later, we are starting to make inroads into non-operative management, but we still have such a long way to go. I returned to New Zealand and then began my research journey. My first master's project was in tissue stiffness of shoulder instability. I wondered if we could activate muscles quicker and switch them on quicker to create greater tension and resistance from the muscle, and whether doing that might reduce the risk of recurrent shoulder instability. We published a paper about this in the Journal of Athletic Training, and I'll put the links below to the paper in the show notes. And this really started my journey into shoulder research. I was fascinated. I then began a PhD into the risk factors of recurrent shoulder instability. And about this time, there was a big push for surgical stabilization of first-time traumatic anterior shoulder dislocations, without a real understanding of who would go on to have instability and who would then just have a single event. It was also really frustrating as a clinician to try the best you can to address deficits in strength and range of movement and proprioception, and then discharge a patient thinking you had addressed all these things 100%, only to have them turn up on your door 6 months later with yet another episode of shoulder instability. And so in my PhD, I wanted to know if we could work out who was more at risk of recurrent instability and whether we could work that out after their first dislocation. And so we firstly published a couple of meta-analyses of risk factors in adults and children, and then used these risk factors to develop a prognostic tool in 2 separate prospective cohort studies to firstly develop the tool and then assess its predictive validity. With the meta-analyses across the literature in the adult population, we found increased risk of recurrent instability in people aged 40 years and under, and those people were 13 times more likely to have recurrent instability. We found increased risk in men compared with women, who were 3 times more likely to have instability, and also increased risk in people with hyperlaxity, who were just over 2.5 times more likely to have recurrent instability. Decreased risk of recurrent instability was reported in people who had a greater tuberosity fracture. We also found the rate of recurrent instability decreased as the time from the initial dislocation increased. Other factors such as bony Bankart lesions, nerve palsies, and occupation also influence the rate of recurrent instability. Specifically for children, we found that the rate of recurrent instability was 73%. Children aged 14 to 18 years were 25 times more likely to experience recurrent instability than children aged 13 or less. There was a non-significant trend indicating that males were around 3.5 times more likely to experience recurrent instability compared with females or girls. Analysis of one study found that children with a closed physis are 14 times more likely to experience recurrent instability compared with those with an open physis. And so back to our population in New Zealand, with our prospective cohort study, we found univariate risk factors that were significant, that having a bony Bankart lesion, being immobilized, decreased your risk of recurrent instability. High SPADI scores increased your risk, as did high shoulder activity scores. High kinesiophobia and poor quality of life also were significant for recurrent shoulder instability. Things that trended to significance, so with a p-value of less than 0.1, was a non-dominant shoulder dislocation and having an ethnicity other than New Zealand, European, Maori or Pacifica, as well as being aged 16 to 25 years and being involved in contact sport. And when we combined all these variables in multivariate analysis, we found that being aged 16 to 25, having a bony Bankart lesion and a dislocation on your dominant side all increased your risk. We found that high pain and disability scores increased your risk, as did high kinesiophobia. And we also found that immobilization decreased your risk. And with this tool, we've created an online calculator on the margieolds.com website where you can enter in the data of the patient in front of you and use this tool to calculate the risk of recurrence for your patient that you're sitting with in your clinic. So hopefully that's useful for people, and there is some clinical implication from the PhD. And from here, my research has taken me to explore other factors that affect people with shoulder injuries. I did a research fellowship in Kentucky in the US with Professor Tim All, and was able then to create and assess the reliability of a test battery that we could use to see if people were able to return to sport after injury. We also looked at some surface and fine wire EMG in these tests, and we published these on the side hold rotation and the line hops in order to establish some validity of these tests. And we're going to talk about these studies in another podcast. Back in New Zealand, we published some data on the normative values of the rugby SARTS test, because we know it's difficult to establish predictive validity in contact and collision sports because of the chance event of a contact or collision event occurring. We thought that establishing normative data might help as a proxy to see if athletes are ready to go back to sport. Alongside Tim and another colleague, Alon Rabin in Israel, we also developed the supine moving apprehension test to better examine people with anterior shoulder instability, as many of those exercises that we've seen published in the literature actually load the posterior cuff and the posterior shoulder and don't really pay any attention or emphasis on the anterior shoulder, when we know that anterior shoulder instability is the most dominant direction for shoulder instability. One of the things also to come from my PhD was that kinesiophobia is a predictor of shoulder instability. And so I've set about trying to understand this further. We know from the PhD that kinesiophobia doesn't change over time and also isn't significantly different between primary or recurrent shoulder instability. I've done some work with Kate Webster, who developed the ACL Return to Sport After Injury scale, and we adapted this to the Shoulder Instability Return to Sport After Injury scale, and along with Jeremeta have then published the Shoulder Instability Return to Sport After Injury scale, and Kate and I have specifically looked at the constructs within this scale. Nico Magni and I have also then looked at the 5-item questionnaire of that CERSI scale rather than the original 12-item questionnaire, and we'll discuss this in another podcast. Also, an attempt to try and understand fear of re-injury and what happens after a shoulder dislocation, I've conducted a qualitative study with Gisela Sol, who interviewed a number of people who had had a shoulder dislocation to try and understand the effect of the shoulder dislocation on their life, what happened to them with the shoulder dislocation. I was really interested in the fear and trying to understand fear more. Was it fear of pain or fear of recurrence or fear of missing out? Exactly what is it that these people are frightened of? I felt that maybe the kinesiophobia didn't capture that as accurately as we would need. And what Gisela found in this study was incredibly humbling, because it's actually not about the fear, it's about the massive social impact and the massive impact in lots of other dimensions of people's lives that having a shoulder dislocation really has. And I think this is an incredibly powerful piece of work, and hopefully we're going to get Gisela on the show to discuss this further, as well as other shoulder-related research that she's doing. Alongside this journey of my research, I've still been working clinically at Auckland Shoulder Clinic with a fabulous team of shoulder therapists. I've also created an online website for postgraduate learning for therapists who are interested in shoulder rehabilitation, and you can check this out at margieolds.com. There's a range of different courses there, from a general introductory refresher course to more specific courses on the scapula, shoulder instability, and return to sport. I've also recently started a Facebook group called Glenohumeral Gurus, and that's what really has inspired this podcast as part of this group. I want this to be a way for therapists to meet online and share knowledge and expertise with each other. The name is actually quite an interesting story, and I've developed this in association with AI, using artificial intelligence to really see if we could expand what it is that we know about creative names that I could use. And the name Glenohumeral Guru really stuck with me, because people have tried to call me a shoulder guru, and I really don't like the term. I think of, in the physiotherapy community specifically, we're really keen to put people up on pedestals and call them a guru. And by doing that, sometimes we lose our clinical reasoning. And so I wanted Glenohumeral Gurus to be a group about all of us, where all of us are gurus and all of us are sharing our experiences and really doing what we can to help create better outcomes for our patients. And so my goal is to create a community with Glenohumeral Gurus where we can learn and grow from each other to ensure that we deliver the best care for our patients. So thank you for joining me on this episode. Don't forget to subscribe, leave a review, share the podcast with your colleagues. I plan to make these podcasts between 10 to 20 minutes long, so you can listen on your way to work or when a patient cancels, and hopefully then they'll be useful adjuncts to your clinical practice. My current plan for these podcasts is that we will vary them between discussions of clinical cases, research roundups where we will review recent research around a particular topic, provide a spotlight on different techniques, and review the research or theory around different therapeutic techniques. I want to interview other expert clinicians and academics who can offer a different slant or point of view on their specialist area of expertise. I want to talk about technology in practice, what we can learn from AI, what might work well and what works not so well as also tips for practice management. As you can see, there's a lot to cover. So if you have any questions or topics you'd like us to cover, then feel free to reach out. Stay tuned for our next episode, where we'll dive into the use of force plates with Ben Onofrio, who's a specialist shoulder therapist in Adelaide in Australia. So thank you for joining me on this first episode of Glenohumeral Gurus. I'm excited to share this journey with you, and I look forward to our next conversation. Remember, if there's anything Glenohumeral Gurus can do to help you help your shoulder patients, then reach out on our Facebook page for ideas, clinical tips, and support. Until then, take care, stay curious, and keep making a difference. Until next time, this is Margie Olds signing off. Cheers. Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way, or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget, you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via telehealth worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.